Okay. Good morning, good afternoon, good evening, everybody from around. Please just note that this meeting is being recorded. We still have people arriving, but I think we'll make a start, and we'll see then as people arrive, they'll be able to catch up. So welcome to this webinar on competency-based learning, which is part of our Learning Saves Lives webinar series. And this series of webinars is really some informal opportunities for us to discuss, explore, and co-create new energy and solutions for issues that we're passionate about. So my name's Andrew Black. I'm an expert in learning and capacity development, and I work in WHO's Health Emergencies Program. These days, we're hearing a lot about the importance of competency-based learning and competency frameworks, but relatively little about how we can actually use these frameworks to build staff capacity. So today, we are joined by panelists from around the world to try and answer three key questions. What are competency frameworks? Why are they important? And how are they used to help improve healthcare during an emergency? So before I introduce you to all the panelists, I want to explain why we're running this webinar and what we'll be doing for the next 90 minutes. So at the World Health Organization, we are working hard to ensure that the learning and training that we deliver is freely available to access, is relevant, and is of high quality. And most importantly, it helps health workers to develop the knowledge and skills that they need to keep 1 billion people safer from emergencies. And we've adopted a competency-based approach to learning because it helps us to move beyond simply sharing information and knowledge to provide training that will help build skills and reflect the realities that our staff working in emergencies face every day. So today we're going to learn from the experience of experts who have used the competency-based approach to help develop learning. Please make sure you interact and ask questions so that we can share our learning. I see there are, I think, over 500 people now participating. Thank you all very much for taking the time to join us. We have a virtual spillover room on YouTube, and for those of you who cannot join us, we've recorded the session. So today is a conversation in two parts. In the first part, we're going to talk to colleagues from Health Education England about their work with competencies, providing learning for national health staff, and we will particularly look at their experience of training volunteers and health staff to provide critical care during the COVID pandemic. In the second segment, we're going to move to look at public health in the global context and the competencies for emergency work and how we've used these in training to prepare people for deployment to the field and to help health staff identify their own strengths and their own areas for improvement. If you have questions for the panelists or the practitioners, please post them on the Q&A, so that's at the bottom of your screen, and we will get them to answer as many questions as possible. And we also use these questions to enrich our discussion as we go forward over the next 90 minutes. Please keep your questions focused on the development and use of competencies. If you have comments to make, then there is the comments box you can use for that. And again, please make sure your comments are related to our topic today. You can write those in the chat, So I think we have some questions to put up, Andrea, I hope that's right. So before we start, we'd like to gather some ideas from you. And you're going to see 3 questions pop up in the window. And please answer each question. You need to scroll down to see them all. And we'll take a few minutes to do that. And then we'll have a look at the results and see how they can contribute to our discussion today. So Andrew, are you able to put the questions up, please?
Yes. Sorry, Andrew, there's something wrong with the questions. Can we do it later in a few minutes? I don't know what's happening with the pool.
Okay.
If we can do it in a few minutes, I will figure it out.
Okay. So we'll just move on then. Thank you. No worries. So let's go to our first panel, which is our colleagues from Health Education England. And thank you very much for joining us, the three of you. Health Education England supports the delivery of healthcare and health improvement to patients and the public by ensuring that the health workforce has the right skills at the right time and in the right place. Health Education England oversees planning, education, and training of the future workforce and development of the existing workforce. And we're going to talk first to Dr. Neil Ralph. He's going to explain to us what competency frameworks are and how they can be used to support learning, staff development, and helping health workers to plot their own career pathways. And then we're going to talk to Julie Coombs and Dr. Libby Thomas, and they're going to talk to us about their experience of using competency frameworks during the COVID-19 response. So first, I'll come to you, Dr. Ralph. Thank you for joining us. Dr. Ralph is the head of Technology Enhanced Learning, TEL, at Health Education England. TEL focuses on how we can make use of existing and emerging technologies and techniques to enhance education and training in health and care. And this includes successful e-learning for healthcare program and developing other enhanced digital platforms and the use of simulation-based education, including immersive technologies. He's always had an interest in technology and its impact on healthcare and education. He's a clinical psychologist and he has experience of working both clinically and in academia. So welcome again, Dr. Ralph. Please set the scene for us. And can you explain what competency frameworks are and how are they used?
Great. Thank you, Andrew, and hello, everybody. It's great to be here. Thank you for joining us. So, Andrew, starting competencies, one's best able to define a competence as a mixture of, or a combination of knowledge, skills, and attitudes needed to perform an area of work. And taking a competency approach is incredibly helpful, we find, when we're considering areas of work within health and care and its delivery. Competencies can be used to help define job roles, to develop learning, so to build education programs, but also to help individuals as learners to understand their own learning pathway, to be clear on what they need to do to support them in acquiring competencies, and whether that they're doing that as part of a formal course or formal education or as independent learners themselves. They help provide direction. Competency frameworks provide us a way of collating a range of competencies together, and which are typically aligned to a role or a particular area of expertise that we want people to be able to demonstrably show they're able to do. We develop competency frameworks typically by identifying what those tasks are, what those knowledge, skills, and attitudes that we want people to have, looking at the evidence base. So what does the evidence or what does best practice look like? And typically they're developed through speaking with experts in the field to validate that this is what we want to see as a range of skills, knowledge, etc., within people who are doing those tasks. And once we've created a competency framework, they enable us to, as I mentioned, either link those to a profession or to look at what are general skills that are cross-cutting that we want to see people in all different roles be able to deliver, and what we want to see people at different levels of expertise within those roles or within their professions. And they enable us to do all of that, but also as part of that, understand what's generalist skills and what are specialist skills too.
Okay, thank you. So it's a way of sort of looking at what people need to be able to do, I guess, essentially to do their job properly, and in our case, to look after affected people or patients. And so once we've got the competency framework and we understand what people need to be able to do, here we're looking at competency-based learning. So can you explain what that is?
Well, competency-based learning is how we then build education programs that look specifically how we help people develop those skills, and developing those skills in a way that they can demonstrate that in practice. They can demonstrate those skills in practice. And if we do that effectively, we're able to, for instance, look, as I mentioned before, beyond professional boundaries. We're able to understand what we need within a particular set of tasks or role, often from a patient perspective. So as we're building our services around patient need, for instance, not around professional role or characteristics. And it enables us to then measure whether we've got the right skill set, the right complement of skills within a workforce to be able to then deliver against those skills that are required. And my experience is the more and more we look at the application of developing competency-based learning, more and more we're seeing interprofessional approaches of education, interprofessional ways of people learning together. And again, it goes back to being able to understand what are those general skills we need everybody to have, to what level of competence, and what are the specialist skills. And that helps us really understand that complement of the workforce, but in particular, how you build effective education programs as well. Doing this well gives an enormous amount of flexibility, but also enables us to have, I think, a better way of delivering a measurable level of higher quality of care to the patient.
Thank you. And so one question that just comes to mind, I'm just wondering, is this, I mean, how is this different to what we might perceive of as traditional education? I mean, does this mark a change in the way that we look at training and learning?
Well, that's a really good question, Andrew, and there's probably a multitude of answers from that. So I'll give an answer from what's coming to mind at the moment. Traditionally within education, we tend to have a focus of a particular set of learning outcomes required, built around an individual that might, for instance, enable them to meet registration in a role, to prove their qualification, and that's underpinned by a curricula that then the learning is developed against to help them meet that. Now, of course, huge value in that approach. It is an approach that's been developed over quite a few hundreds of years that underpins formal education. What I'm seeing through taking a competency approach based to learning is being able to take a step back on that and look more holistically in terms of this is what we need to achieve for our patients against the different healthcare issues we're trying to mitigate. This is what we need as a team around that. This is the available people. These are the people available to us to help us deliver that care. And what you can do with a competency-based approach is you can really start to build a much more holistic, targeted education program of education. Sits alongside traditional education for sure, but actually I think augments or adapts, extends the reach of that, and enables us to, I think, stretch individuals who come with a particular skill set, extend those with other skills that they didn't get within their formal education. And I suppose underlying this is what you then get is the ability to provide that care, I think, much more effectively, but also to look after the people who are delivering that care too. And again, competency-based approaches to learning need to understand how they function within a system, not just as an individual with a set of tasks to do.
Thank you. Thank you. And then, so my final question for you before we move on to hear about how competencies have been used in a response is, I know you've been developing an app that will help health workers to look at their own competencies and assess the learning that they need to move forward in their careers. Why is this so important?
Thank you. So I do have the privilege of running a team that looks after and develops internet learning platforms for healthcare workforce across England and into Scotland and Wales, Northern Ireland too, and which gives us enormous reach out to learners, and we're very privileged to be in the position to be able to do that. But when we talk to learners or to people who commission education, we're very aware that we're engaging with people who are very time poor, where it's very difficult to build learning in around their the demands of their day-to-day work, and at the same time they always need to, or will be encouraged to, through a formal program or as independent learners, understand what their skills are and look at how they can continue to develop themselves within whatever task they're doing, or often, as we know over the last, particularly the last year, rapidly adapt to new roles and new tasks within their healthcare environment. And so we want to make use of our reach via the internet, via digital tools, to try and remove a lot of the effort from individual learners. So one of the ways we can do that is by giving them dynamic tools that enable them to assess their competencies whenever they want to, not necessarily at a point of an appraisal or review where they have a paper copy or a competency framework, but actually on an ongoing basis whenever it's necessary. The power of that, though, it empowers the learner and enables them to independently seek out learning or to see how they're doing engaging with a formal program they've been asked to work on. But it also empowers the educators or the commissioners of education, because through digital approaches, we can collect information that information can drive decisions. So if people are time poor and money is very tight, we can be much more efficient in how we target that education to best meet where those gaps are within the individuals. Doing things over the internet via this app will enable us to do that at scale.
Thank you very much. So thank you for that very informative introduction, Dr. Neil. And so we're going to move on now and talk to Julie. So Julie Coombs started working in the NHS in 2000 as a paediatric nurse and then an intensive care nurse, and she's been involved in education since 2010. She's currently the lead for the London Transformation and Learning Collaborative, which is an NHS programme that was formed to help train health staff, including surge staff, to fight COVID. In 2020, Julie was tasked with developing the training for the health staff and other members of the public who volunteered to work in the Nightingale hospitals. Now, the Nightingale hospitals are essentially enormous field hospitals that were set up by the government in the UK in preparation for the feared spike in patients, in COVID patients. I think 6 of these hospitals were set up over a matter of months, and they were designed to hold hundreds of critical care patients. So Julie, welcome to you. You were asked to train all of the hundreds of surge staff needed for these hospitals. Can you tell us what happened?
Yeah, thank you, and good afternoon, everybody. I think we were in a situation that a lot of other people have experienced over the last 9 months to 12 months. I had a call from my director to say that a field hospital was being built, and this had been commissioned by the government. that the projections of the growth due to COVID and the need for increased beds in critical care was going to overstretch the amount of beds that we had available within London. And that would mean that there would not be enough capacity and therefore not enough staff to be able to look after those patients in the hospitals that we had. Over the next week, so this was on a Monday, the following Saturday, I was told the hospital would be opening. A convention centre was being transported into a critical care unit. 500 beds would be opened, and there would need to be 400 staff that were trained for that opening the following Saturday. Within 2 weeks from that, they were projecting that following 4,000 beds would be required, and therefore 60,000 staff would be needed. When you get that type of information and asked to deliver training, there are a few questions you usually ask, such as where is your workforce coming from? What level of experience do they have? What are the types of roles that they're going to be undertaking and the tasks associated to that? And what's the environment they're going to be working in? We didn't have a lot of information or answers to those questions. In terms of where the workforce was going to come from, it was volunteers, and those volunteers would be anything from a surgeon to a canoe instructor, to a dressmaker, to a pub landlord. So there was absolute diversity in terms of the workforce. We had to really challenge and ask what type of roles were going to be undertaken, so that we could really define the type of training that these individuals would require, and therefore the type of roles that they would have to undertake. So there was a lot of ambiguity, and we needed to create some standardization to enable us to deliver training that was appropriate for the environment that individuals are going to be working in.
Remember to unmute. This sounds like an incredible task, actually, under an amazing amount of pressure. So how did you make sure that the volunteers who arrived were trained in the best way and could do what you needed them to do?
So we spent a lot of time working with our clinical leads to really understand the roles and the clinical model, and therefore what were the abilities, skills that they needed to have to undertake that. So we sort of prescribed what a competency framework might look like and the learning objectives associated to that. We then had to look at the types of individuals that were coming through as volunteers and identify the roles that they could undertake, considering the level of training that they had previously had and the amount of training they would need to undertake this role. Because we had large numbers of people coming through, up to 250 people a day, and we were experiencing the suggestion there may be up to 500 people a day, we needed to stream and cohort these individuals. And we cohorted them into sort of red, amber and green. Green were those individuals that had already worked in critical care, were going to undertake a role that they had previously undertaken in the last 2 years. And they had a set training program for them, which was shorter and focused and directed to what they needed. We then had amber, who are individuals that were professionals, registered professionals, but had never worked in critical care before, and they had a longer program of training. We then had our red group, which were those individuals that had never worked in healthcare before, and they had a longer bespoke program and identified roles that they could undertake within the critical care environment.
Thank you. So that just sort of reinforces not only about the skills, it's about knowing who's coming and who you need, who you're actually looking to train. And so, I mean, lots of us working in emergencies, we know that they can be unpredictable, that the situation is constantly changing. So how did you deal with that?
Like I say, we made assumptions of what the work was that people were going to be undertaking. We imagined a competency framework related to the tasks and skills that they would need. The hospital then opened, and then we gathered a lot of data of exactly what was the work that people were really going to be doing. And there was a gap between what we had imagined and prescribed to the work that people were undertaking. So therefore, we had to have feedback loops from the clinical setting of data that told us where we needed to adapt and change the training that people were doing. This was really important because if we were having around 250 people a day that were being trained, we needed to act very quickly in adapting the learning that people were undertaking, because you would have 250 people that needed to be retrained and additional skills provided as time went on. I think what was really important was identifying the safety critical training. We had limited time. And we needed to ensure that there was enough of a workforce to deliver care to the number of patients that were projected to be admitted. So with that, we talked about safety critical, both from a psychological safety of the individual that was going to be working in an environment that could be deemed as hostile, and also the technical safety of that individual to make sure that they actually gave safe care to a patient. We had a lot of team training, and we reenacted some of the skills and some of the scenarios that they would be expected to undertake when they're working in clinical practice. So there was a real focus on the must-do type skills, and those that I said that are safety critical. What we really learned also is that learners can only take on so much information. So you could have a training program that is 12 hours long, but the amount of information that an individual can retain and then take into practice is limited. So we needed to really understand what the baseline knowledge of individuals were, so that we could ensure that the training that was provided was focused and enabled them to then take that into clinical practice within a timely period.
Thank you, Julie. So some key sort of messages are around knowing your audience, and then also, not overburdening them. So, deciding actually what they really need to know, I suppose, and what you can afford to put later down the line. I think we've got some pictures, because I know some of the people in chat have been asking for some pictures. So I wonder if you could just take, Andrea, if you could put the pictures up, maybe Julie, and you could just explain them to us quickly.
Sure. So we had a Nightingale education team. So it wasn't just about making sure that people had the right training. We had to also build a facility and a faculty within that time. So we needed to ensure that we created a team image and a sense of belonging for the faculty that were going to be training the staff. This is the Nightingale Hospital. You can see the conference centre behind. And if we go to the next picture, you can see what we started out with, and we worked with the military quite closely, is actually setting out some tabletop exercises in the area so that we could really understand how the hospital was going to function. So we undertook some simulations before the hospital opened. And the next picture is just a bit of an overview of the build that occurred. And you can see the size of this and the enormity of it, and the progression that it went through over the sort of 7 to 10 days that it was actually built. And if we move on to the next slide. And so these are just a couple of pictures, if you want to just go through them, which just really depicts what the conference centre looked like and how it developed into a critical care. And to the next slide. So in regards to the training, like I said, we had to make sure that we were training large volumes of people. We needed to make sure we had a space in which we could do that. And the O2 is a event centre in London. And so we took over the O2 and we recreated the hospital in the O2. So you can see this is the simulated environment and how much that it actually mirrors the image of the hospital that the individuals were going to be working in. Part of this was so that people could get used to that type of environment and the ways that they were going to have to be working before they actually went into clinical practice.
Brilliant. Thank you, Julian. I know we're going to talk a bit about simulation later as well, so we'll come to that later. I can see the questions piling up, so we're going to go first to Libby, and then we'll try and take some of those questions. So Libby is Dr. Libby Thomas is a clinical academic with a passion for emergency medicine and medical education, and she has a PhD in medical education. She's an emergency medicine consultant at King's College Hospital in London, and she lectures in emergency medicine. She's currently the education lead for the London Transformation and Learning Collaborative, and has been leading the education arm of the London Transformation and Learning Collaborative to support cross-skilling of London NHS workforce to manage existing critical care demand, potential future spikes in critical care requirements as a result of COVID-19, and a longer-term permanent expansion of critical care capacity across London. So welcome to you, Libby. This project potentially encompassed anyone in healthcare who might be redeployed to critical care. So, but when you were looking at competencies needed by your staff, you started by looking at patient needs. So could you tell us about that, please?
Absolutely. Thank you for having us this evening. And it's an absolute pleasure to be here and to be with so many people from around the world. So we moved from the Nightingale on to being tasked with managing the critical care surge in London. So London currently has about 870 critical care beds, and there's predicted surge to up to 100% of that more, so 1,600 critical care beds, but we don't have the staff to manage 1,600 beds in a way that we would like to, which is normally with a 1-to-1 nursing ratio, a 15-to-1 consultant ratio, and everything else. And so what was really key for us was to think about what was it that the patient needed, and then to base our competencies from that, and then to which staff we could use in order to match those needs and those requirements. So we recognised that we'd have to increase the bedside patient care. So we still had a 1-to-1 ratio, which were managed by a critical care nurse who might be managing the 2-to-1, 3-to-1 or 4-to-1 ratio. And we also still needed the specialists as well. And those specialists weren't normally working in critical care either. So for the bedside ratios, we had to think about who else could come in and do these bedside roles, and which were the competencies around the bedside that required either a critical care nurse or somebody who had a professional registration in either nursing, medicine, midwifery, physio, occupational therapy, dietitian, pharmacy, any of those that counted as professional registered in the UK, which gave them certain rights and clinical rights to work with patients. And then actually, which roles do our poor staff have to do that they don't need any qualification for at all, and we could offload completely? So patient washing and care, restocking, managing equipment, and other things like that. And how could we actually really manage these different roles? So we took the patient, thought about everything they needed to be done for them. We used the framework we built at Nightingale, and then we kind of siphoned off what definitely needed a critical care nurse in order to cover it, what definitely didn't need any professional qualification to cover it, and then what could we get everybody else to try and cover. In addition to that, we looked at the competencies required for, say, a pharmacist or a physiotherapist or a doctor who didn't normally work in critical care in order to be able to work in critical care to a safe level, and also to enable those critical care staff to know what were the minimum competencies of the people coming to them, and so that they could take that. So that's how we went from the patient needs and built it up. As Neil said earlier, it was really interprofessional. We had time poor, stretched people who were being forced into these situations really quickly. So this allowed them to quickly look and see what skills it was that they potentially needed, and how they could then try and acquire those skills and that learning, and then how they could feel more competent and ready to take on these roles.
Thank you. And I understand from your description there, I mean, there's so many roles, but only so many staff. So you had people, you had registered support clinicians, so doctors, nurses, and non-registered support staff as well. How did you manage this? And were people swapping roles at all and sharing jobs?
Yes, thank you. So in some areas, they managed to recruit in non-registered support staff specifically to work within ICU. And they did that in the first surge, and then they maintained these people on for the second surge and forwards. And actually they started training in the specific competencies And we've developed a passport that outlines what those baseline competencies should be, and they're then extending their practice. Likewise, for the registered support clinicians, there's a passport of the most fundamental competencies that we want that critical care nurse to know that whoever it is working at the bedside can do. But actually what we saw, and I think this was seen around the world, was the camaraderie and the joining in together, and people going, they just need bums on seats. Actually, they need feet on the floor, don't they? People in scrubs who are there, who can move patients, who can wash patients, can do whatever's asked of them. And we had consultant cardiologists, consultant neuroradiologists working in the non-registered support staff role, because that's what was needed. That's where the limiting factor was. And they were given time from their normal jobs to go and work in those roles. And they just got on with it, you know, and that's what was really, really heartening, was this, just everybody was like, right, what needs doing? Just tell me what needs doing, or define what needs doing. And as we know, if what's defined what needs doing, then it's easier to get on and do it and delegate it. Because one of the real challenges was these junior critical care nurses who may have only been in the job for 1, 2, 3 years, having to delegate to a consultant, to delegate to a matron, to delegate to somebody who they felt much more senior and say, oh, could you just wash the patient, because I'm going to go off and do all the drugs. And that felt uncomfortable. So we had to empower them by saying, no, this is appropriate. This is what only you can do, and therefore you save your time for that.
Thank you. And that just shows the importance of these interprofessional transversal skills, you know, the communication and having the ability to do that. My final question to you is that we spoke earlier about how emergencies are uncertain, and you're asking people to work in environments with which they're not familiar. So was there anything special that you did to prepare your staff to manage that uncertainty?
Absolutely. So we did a lot of engagement with our stakeholders over the summer after the first surge, and trying to find out why people were feeling how they were and what have been the real challenges. So some of those, what I just described about delegating down, some of those were the lack of preparedness. Some of that is inevitable because decisions were changing on a 12-hour, 24-hour basis in the first surge, and that settled down as we moved into the second and the third, and we understand the disease a bit more. But what we know is the better prepared you are going into a role, the better you are going to be coming out of it. So in the army, you prepare for warfare, you prepare and you simulate and you go through these things hundreds of times. And then when you've been abroad, you also come home and you decompress and you have an opportunity to debrief. And we just didn't have that space and those things going on. So some of the specific resources we developed were about trying to get people to understand these challenges, understand how they were feeling. There's something called moral injury, and I'll put a link to our film that we made about moral injury in the group. But actually, this is normal. We're all feeling slightly weird and slightly not right. And it's not because we've done the wrong thing. We've just been pushed outside our comfort zone, and we haven't been given enough of the tools because there wasn't the time available to do that. And so by the London Transformation and Learning Collaborative was about, let's prepare the staff in advance of the second surge and third surge. Let's give them that preparation, give them that opportunity to get themselves better. And somebody in the questions, if I can come to that briefly, asked about how do you acquire competencies online? Well, a lot of the competencies we're talking about are knowledge, they're refresher, they're taking them back to when they were in their healthcare professional school. And so we can provide short, sharp access to films, to PowerPoints, to explanations, and they can go over it, and they can go over it in their own time and at their own speed, and they can watch it once, they can watch it 25 times, whichever. And so they can prepare online. And there is nothing like getting on the floor and putting your hands and pulling all the pieces together. But there's a lot that goes on in education that we can do before that final stage. And actually, people just wanted to be told where to go, where to get resources, how to help themselves, which feeds into another question about skill maintenance and, you know, how do we manage that skill maintenance? And actually, people are self-directed. People don't want to go to work not knowing what they're going to do. If they get told, actually, this is going to be the ventilator you're going to use, this is going to be the feeding tube, they can actually revise, they can look it up in advance. And we've created equipment matrix. They can rapidly access the user guides and the quick reference manuals to all the different equipment you would find within an ICU in London. You know, we've done it within that. We've given them rapid access tools for 360 for the ICU, so they can click on any of the different equipment and they can learn the basics. This is an ET tube. It goes down somebody's throat. It's connected to a ventilator. Or they can take it up to another level and about how things interconnect and how they are important, you know, how to transduce arterial line, for instance. And so actually People want to be empowered, people want to be given the opportunity to learn, but it's making it accessible and making it in one place and making it in a way through a competency framework, which is what this is all about. They can rapidly go down and go, I can do this, I can do this, I can't do that. Where's the resource? We've told them where the resource is, they can go and do it, and then they can do their own self-development.
And thank you very much, Libby. And yes, I've been watching the questions come up, and so that last one was one that I was keen to see as well. How do we maintain those skills? And you answered it so eloquently. Thank you. So, in the interests of time, we will catch up, I promise, with the other questions that are coming in at the end. But I think some of them will be answered by our next panel. So, for now, what I'd like to say is thank you very much to the three of you from Health Education England for sharing these experiences and these real life experiences of using these frameworks and tools in an emergency. It's been fascinating learning from you. And so for now, though, I'd like to move from the UK context and start talking in the context of public health and global public health. And we're joined by three panelists. Professor Michael Stoto from Georgetown University. He's also an adjunct professor at the Harvard T.H. Chan School of Public Health. And he's going to talk to us about a competency framework that he and his team developed for use by countries in Europe. Then we're going to look at how we at WHO are using competencies to train individuals with Oliver Stucker, who's a learning strategy expert with the Health Emergencies Program. And then we're going to talk to Dr. Jerry Jonas-Mbasha, who has very kindly taken time out from his work. He's a health cluster coordinator, and he's currently in Burkina Faso. And he's actually been through the training and assessment that Oliver's going to talk about, so we'll be able to understand what it's really like. So first I'll come to you, Professor Michael. Professor Michael is a professor of health systems, administration and population health at Georgetown University, an adjunct professor of biostatistics and a senior preparedness fellow at the Harvard T.H. Chan School of Public Health. And by background, he's a statistician, epidemiologist, health services researcher, and an expert on population health and public health assessment. His work in this area has included systems-oriented evaluations of public health surveillance systems at the local to global level and addressing both statistical methods and public health practice issues. But the reason he's here with us today and part of this panel is that in 2017, you produced a public health emergency preparedness competency framework for EU member states. Can you just start by setting the scene for us, please, and what led you to do this work?
Well, first of all, thank you, Andrew, for the opportunity to be here and the other organizers. And thank you to the panelists from the first panel. I thought that was really interesting, and I think that you'll see some resonance with what I have to say. And of course, thanks to the participants for wherever you are around the world and whatever time it is, good day. Thank you for joining. Well, the ECDC had a long-term goal of developing training programs intended to improve public health emergency preparedness. The first step that we worked on them, on which was to develop a logic model for public health preparedness in the European context that laid out what are the competencies and the capacities, what are the capacities and the capabilities that countries need to address public health emergencies. And this provides a structure for assessing how prepared countries are and how they can respond. And also a language for describing and identifying the gaps in knowledge and skills and other competencies that public health professionals and other preparedness professionals need to respond effectively during an emergency. So building on that, in collaboration with the University of Bologna, we've subsequently developed and pilot tested a curriculum based on this competency model.
Thank you. Sorry, I was trying to find the unmute. And so, I mean, we've heard a bit about it before, but why are frameworks like this so important in emergency work? What's particular about them?
Yeah, I think that what the British panelists said really answered that question very well. But let me just take another look at it from a maybe one step higher, not just health professionals, but public health professionals dealing with emergencies, and on a global level. Well, if you're a doctor or a nurse, or a carpenter or a shoemaker, you can learn about what you need to do in your job by apprenticing to a master. And after X number of years, you'll see enough cases so that you'll develop the knowledge and skills that you need. Well, if you think about it, that clearly doesn't work for public health emergencies, whether we're talking about COVID-19 or something less extreme, where many people are required to act without the benefit of professional experience in the area in which they're acting. In fact, one of the meta skills that we now know is that we need to know how to adapt as the situation changes. So the kind of skills that people need, involve public health professionals who have not experienced a major emergency. What do they do now? We saw that with medical professionals in the first panel. But also we need to think about other professionals, policymakers, physicians, school teachers, administrators, and so on, who don't normally think of themselves as part of the public health system. All of a sudden, in a pandemic, have to really think differently about how to address some of these issues. So in order to develop our competency model, we started by analyzing cases to see what the system needed to do to respond to different kinds of cases involving infectious diseases and other cross-border threats to health. And then based on that, we then identified what are the competencies that people working in that system, what do they need? And we had to recognize, of course, that these vary according to the type and the level by job responsibility. They needed different types and levels of knowledge and skills. And then we had to do it in a way that was sufficiently general so that it applied to different public health systems and different levels of development in Germany and Italy and Croatia and all the other European countries. So the challenge was to come up with something that was sufficiently general that it applied in a variety of settings for a variety of different kinds of professionals, but at the same time was meaningful and could be used to think about what training needs there were.
Thank you. And I've seen actually a number of questions asking about this, how do these competencies work when you're dealing with sort of cultural differences as well? So maybe we could come to that later, because I think maybe Oliver and Jerry might have something to add on that as well. But it does lead me to my sort of third question, and I started off with this. We talk about frameworks. We've heard about how they're used to train individuals. But in your opinion, what would be some practical steps that countries can take to use frameworks such as yours?
Well, first of all, I think we need to learn from COVID-19. I mean, obviously, the pandemic is a horrible tragedy, but on the other hand, it really has given us an opportunity to learn about how these systems work and how they didn't work well, and what they need to be able to do. So the countries that have, every country has experienced COVID to some degree, need to really think through what were the challenges that they faced in terms of the systems that they have and the professionals working in those systems, and identify what are the strengths and the weaknesses of their capacities and capabilities, including the people who work in these systems. I think the next step would be to make an inventory about which organizations and types of professionals were involved in the response. And we think of this from a whole of society approach. It wasn't just the public health professionals. And then to think about what competencies that people working in these positions need to perform their job effectively. Again, it's very much like what we saw, what the British panelists said, but bringing it up a level higher to everyone involved in responding to a public health emergency. And then finally, to develop training courses that are tailored to specific competency gaps. And based on the work that we've been doing, both with ECDC and in my teaching at Georgetown, I've got two suggestions that I think are important. One is to incorporate interdisciplinarity in these training programs. You don't want public health officials and school officials and lawyers confronting difficult decisions to be doing it for the first time in an actual emergency. You really would like to have an opportunity to train people, give them that kind of experience. And then another thing related to that is to use simulation exercises as part of these training courses, so that the learners have to deal with an emergency and can develop kind of the interpersonal skills that are needed to do that, and understand what these other kinds of professionals, the way they think about things. And I think that by doing that, we can develop people who work together in terms of the system more effectively. I think, coming back to the cultural question you raised just before, I mean, I think that's a big part of it. A big part of the cultural differences are the different perspectives that people have. Not only different types of health professionals, but public health versus medical types, public health versus decision makers and lawyers and people who run schools and everyone else, who have to really come together to understand how all of these types of professionals can work together to deal with a pandemic.
Thank you, Professor Michael. So there's some very clear messages coming out about interdisciplinary, being able to work sort of across these professional disciplines, but also sort of cultural differences and the perspectives that different professionals will bring to this. And then, of course, I think all of you have said the importance of practice and practicing and working with each other. Thank you very, very much for that overview. And so what I'd like to do now is turn to Oliver Stucker. He's a technical officer in the Learning and Capacity Development Unit with WHO's Health Emergency Program. His expertise is in the field of institutional capacity development, strategy development, and change management. He likes complex challenges and to address these challenges in systematic ways. Before joining WHO, Oliver worked with the European Commission and a number of international NGOs. He holds a master's degree in development administration and European legal studies, as well as a bachelor's degree in social anthropology and sociology. And in his work of over 20 years in WHO, he's contributed to a number of key initiatives. He designed and managed the first program that systematically scaled up the work and core capacities of the emergency program. He was part of the team that developed WHO's first risk communication guideline, which is such an important part of public health work today. He's also one of the parents of openwho.org, which is the learning platform, and he's a co-author of the WHE and WHO learning strategies. Together with other members of the WHE team, he's also developed a framework of core competencies for emergency response, and he's developed methods to provide learners with targeted competency-specific feedback. So welcome to you, Oliver. You've been looking at transversal competencies, or these interdisciplinary competencies, those skills that we all need to function in work or society, and you've been dealing with a very diverse set of people and skills. So how did you approach your work looking at competencies for people working in health emergencies?
Thanks, Andrew. Yes, indeed, emergency response actors are a very diverse group of people, and they come with very different sets of skills and competencies. And I think we've seen some really great examples in the earlier sessions during this webinar. We obviously face this challenge to bring some order into these competencies, and we've divided them into two big groups. So one set or one type of competencies that we looked at and that has separate frameworks to deal with are the competencies that are related to the role of the actors. So these are what we refer to technical competencies, and they can be, for example, in the area of logistics, epidemiology, infection prevention and control. So these are really competencies that individuals acquire through their professional education, through their professional work, and that are built up this way. There is also what we call transversal or soft competencies. And these are actually, or we identified them or defined them as competencies that are required by anyone responding to an emergency. And we already heard some examples from Julie and Professor Michael and Dr. Libby as well, what these competences are. So for WHO specifically and the emergencies program, we actually were faced with a challenge that's different from Julie's case, where she had to build up competencies in volunteers. We actually realized that most of the responders that work with WHO or together with WHO are actually very much technically competent. They have the education, they have all the degrees that you can imagine, they have the experience, but they struggled with the integration of their expertise into response operations. And we thought, well, this is actually curious, and that's why we focused on these competencies that you could loosely say that hold emergency operations together. So we developed this WHO competency model, which focuses on these core competencies in consultation with experts from other agencies and from partners, NGOs, and so on. This was important to us because we feel that this is not only about WHO, but it is about everyone working in the response arena. Now to give to our listeners an idea what they are and how we group them together. So there are 7 big headings for these cross-cutting or vertical competencies. So they are the knowledge and the literacy of the organizational and emergency response system. So it's knowing about how in a big way the response system works. It's the ability to perform in changing contexts. So this is what Professor Michael alluded to. It's the adaptability, resilience, all of these competencies qualities that you're actually not trained for. Then there is an ability to apply and share your technical knowledge in a response context. So to be able to interact with people who might not have the same level of education or not the same cultural background as you have. There is a communication component to it. We have teamwork, we have work in partnerships, and we have leadership. So there are really seven big headings that we have identified, Andrew.
Thank you very much. So with these types of skills you're talking about, the sort of transversal skills, these things around communication, leadership, I mean, they're very difficult to define and to measure. So how do you do that?
Actually, what we've done, we've broken down the knowledge, skills, and attitudes that Neil had explained so nicely before, related to the competencies, so the 7 big groups that I just introduced. And we actually divided them into observable behaviors. So observable behaviors are really a mix of knowledge, skills, and attitude. And under each competency, we have developed 6 to 10 different behaviors that one could look at. So, for example, if you take communication, this would include, as Dr. Libby's talk illustrated, that they include active listening. So listening to the person that is in front of you, the emotional, cultural intelligence that was really alluded to by Professor Michael. It is about negotiation, and it's about analytical and concise communication, for example. So these are all behaviors that we have identified and scaled, and they all make up the competency of communication. Now, applying them to a specific group of trainees or learners, if you want, we actually use simulation exercises. I'm not the first one to mention them. Julie has, and others have done that before. So it's really one of the tools that is being used. And we trained observers to watch these events, if you want, that are happening during simulation exercises. So, for example, coordination meetings with partners or other interventions. And for each of these events, we have actually broken them down beforehand so that observers actually know what they should be looking for, but also they are usually, they are always related to learning opportunities that the participants in trainings had before. So this could have been through online learning, classroom learning, but it's not cold, but there has been learning done before. Then during the simulation exercises, the trained observers, they look at the participants, the training participants, and they note down their observation in a structured format that we have developed for our simulation exercises and trainings. These observations are then compiled in a database and analyzed. Now you say, well, what do you get from a single observation? Yes, probably not much, but actually in an average event that runs 1.5 days, our observers will note about between 3,000 and 5,000 observations for a cohort of 20. So it's really intensive work for observers who have to note this down, and it requires some logistic to all note it down. These observations are, I think this is important to mention, they are not done to obtain an overall score and to say, oh, here is your score, but they are really used as the basis for developmental discussions to help staff identify their own strengths and areas of improvement. So it is clearly not comparative that two participants can compare their score and say, oh, I'm more competent than you are overall, but it really is to help learners and the faculty to actually support learners in their journey, Andrew.
Thank you. And so that raises the question of you do this competency assessment of people, and then you give them some feedback, and how do they normally react to that?
Yes, thanks. It's a whole process. So you don't come and you give feedback, but the competency discussion really, the way we do it, it starts with an in-brief. There is also some background materials and online learning that we've developed, so people understand the competency framework that we are applying and so on. So they don't come in cold and we assess them. So that's the first step. Then in an in-brief, actually the facilitators of the simulation exercise, they have a discussion with the participants and do some sort of a self-assessment or a reflection of participants on their where they feel confident, where they think their strengths are, and also the development goals that they have based on such a framework. We then run the simulation exercise the way I described it earlier, and then we have an outbrief. Again, the main role of the facilitation team is to listen to the participants. So we listen to their self-assessment, structured around the competencies, obviously, and then as a last step, really the faculty members who are in this outbrief, they provide a summary on the observations that the entire faculty has collected. Now, what's really striking about these outbriefs is that there is actually a very strong alignment between the self-assessment of participants and the observation of the faculty. We usually end the discussion on exploring potential avenues for development. So if individuals really say, I would like to develop more skills in this field, or I feel really confident in this field and would like to have further deployment opportunities or so on, that's really where we then navigate through this. You also asked why I think this is useful to participants. I think it is useful because the competency framework actually helps participants to structure their thinking around the strength and personal preferences. And we have seen many cases where people actually reflected then on their choices so far, on the roles they would take in a response and in future responses. So in summary, I think it's really a competency framework, and the application of it is really a self-reflection tool for participants that they can even apply in a daily work context. So well beyond the training event. You have a framework, you can use it, you can go back to it, and you can apply it. So this helps then to identify the development goals. It helps you prepare for deployments, or if you're in a deployment situation, you can take the framework back and ask yourself, what are the behaviors that will be required in this specific situation from me, and refreshing your knowledge and so on. It's similar also what others said before. So it's really about getting ready for the deployment situation.
Brilliant, thank you, Oliver. And I suppose that I'm just reflecting that sort of knowing your strengths and your weaknesses is probably all part of the kind of mental preparation that Dr. Libby was speaking about earlier. And so now, what I'd like to do is talk with Dr. Jerry Jonas, because he's actually been through the training and then used it. Dr. Jerry Jonas Mbasha trained as a medical doctor, and he's currently working with the World Health Organization as the Health Cluster Coordinator in Burkina Faso. He's worked for a number of different international organizations, such as Save the Children, the International Organization for Migration, the International Rescue Committee, and Mary Stopes, amongst others. He's a medical doctor, but he also has master's degrees in general public health and epidemiology, and he also has a PhD in public health from Texila American University. He's been working in emergencies for the last 14 years, mainly providing health and nutrition programs and responding to public health emergencies, including disease outbreaks in sub-Saharan countries. So welcome to you, Jerry. You're currently in Burkina Faso in a complex situation with many challenges. What to your mind are the key competencies that someone in your position is using?
Yeah, thank you very much, Andrew. Just to provide some background about the country, just to let you know that Burkina Faso, it's a West African country, and it's facing a complex humanitarian environment with emergency going on. We have to date 2.5 million people in need of humanitarian services, and we have a plan for health sector to respond to 1.9 million people. So half of the countries affected by conflicts. We have basically 6 regions out of 13 which are facing this conflict. As a result of this conflict, we have 1.2 million people being displaced, and multiple outbreak has been reported in several regions. So we have also have facilities which are now being closed due to these attacks. And approximately 1 million people do not have access to medical services due to these attacks and humanitarian crisis going on. Now, coming back to your questions in terms of competencies, what I would like really to highlight. And I'm lucky because after being trained, I was quickly deployed to the field. So I was still in a very acute phase of learning, and I could be able to quickly deploy those skills which I was provided. And 3 of area captured my attention. So the first one is about coordinations. When you look at Burkina Faso, we have activated the health cluster, which I'm leading as a health cluster coordinator. We have 48 health cluster partners. And all of these health cluster members are coming with their goals, with their way of working. And you have actually to deploy particular skills as health class coordinators in terms of managerial capacity, diplomacy, communications. So all of these aspects need to be bring together and to make sure that you can be able to coordinate actions of these 48 partners. Of course, in the same aim to provide relief to this affected population. The second aspect when it comes to competency, it's about multi-sectoral situations analysis. And this one I really want to emphasize and to highlight key points. The participation of health cluster among other clusters when it comes to multi-sectoral evaluations in humanitarian context, it's really very important. And to mention one example very quickly, just one incident happened over the weekend on the night of 5th June. An armed group attacked a village in one of the regions called Sahel regions. And they unfortunately killed 135 people, and they forced more than 7,000 people to leave the area. And 3 health facilities were also forced to close. So a multi-sectoral evaluations was conducted. So this is an incident which happened when we were not really planning to go for it. So this is just an incident which happened again over the weekend. And quickly, in a coordination mechanism, we have to bring all sectors together and to think what can be done in terms of a response. And of course, when it comes to health, I have just to make sure that everything is in place, partners' capacity are detected and able to be deployed to provide what's needed to these displaced populations. And other sectors have to work on their sectors as well, like WASH, FSL, food security, shelter, and other protections aspects. So you have really to make sure that you deploy skills to work in a multi-sectoral situations and be able to provide or share what needs to be captured as for health sector. So this is sometimes very challenging, and when you have to raise the voice for health, and you have really to make it very sound to people to make sure that at the end of the day, whatever conclusions must be taken, of course, in the aim of bringing the public health response to affected people, health should be considered as a priority. The other aspect which I would like to mention, it's about response to epidemic outbreak. Over the past 12 months, we have faced several outbreaks. I've counted 7. And each outbreak brings a different way of working. So you are obliged to bring in different skills, different way of working. That has been mentioned by other panelists, like how are we bringing in worker force to work as in a system, not like an individual. And that was also highlighted by Oliver. How do you bring particular skills like communications to make sure that everyone is aware of really what you want to do? And what was really, what captured my attention is when it comes to this outbreak, you see from the same outbreak like measles, but you may be asked to deliver different approaches in different regions. Now imagine facing 7 outbreaks, and that's a complete several aspects of response you are required to deliver and to make sure that through particular skills, you can be able to settle or send a required response to this outbreak.
Thank you, Dr. Jerry, for that. Reiterating some of those lessons and showing how, even from the sort of clinical care, understanding the situation you're in, understanding what other people can do and how to work in that is so important. I know you've been through the learning program that Oliver was describing, and part of that was designed to allow you to practice some of your skills in a simulated environment. How did that help you prepare for the task you're currently undertaking?
Yeah, thank you, Andrew. So you see, from my background as a medical doctor, I came with a classical approach and looking at how I can deliver services based on individuals which are in need of particular health services. That was the approach that I had until I go through public health studies and different aspect of looking at different public health events completely changed. But this wasn't really enough until I go through these simulations to find out that I really need to adapt and to develop additional skills which are required and to deliver particular work response which is needed. So as of part of this training which I completed, the best part was that simulation exercises which actually helped me to develop and to look at different public health issues, public health problems. Those helped me to develop additional skills which are completely different from those one I learned when I was at medical school or in public health studies. So this was a particularity of that simulation exercises. And also having this kind of experience-based learning, it's really very helpful. You are faced with different situations, as I've mentioned, facing epidemics, facing other humanitarian situations. You really need to be prepared for such situations. And for me, these simulations provided me with enough skills, which I'm now using currently for this response in Burkina Faso. And that has been actually highlighted by other panelists like Oliver, say that other skills may be required based on public health events you are facing. And that capacity to develop or recall those skills you've learned from these simulations, it's a best part of the exercises. And based on that, following such path, you will be successful in whatever you are doing when you are deployed to the field.
Thank you. And just a very quick final question for you, because we're running short on time, but I just wondered, we spoke about the competency learning, and you were observed and then you received the feedback that Oliver spoke about. How did that make you feel?
Yeah, that was the difficult part of the exercises, because I remember when we started, you started being observing observers, how they are looking at me and how I should behave to make sure that I'm not going through mistakes. And after a few minutes, the pressure starts increasing. You are asked to deliver particular materials. You are asked to go through meetings. You are asked to develop proposals. You are asked to do particular tasks, and you really forget that you are being observed. So that happened at a certain point, and you start now delivering or facing real-time public health situations in that exercises. So that was really amazing. And the other things, it's when you are working in such environment, you have to deal with this multicultural aspect that was really very important because you meet people with different backgrounds, with a different culture, and you have to adjust yourself very quickly to make sure that you are part of that team and deliver what is expected from you. And in terms of now feedback, that was really useful, and I really like the way observers go through that feedback, and which helped me a lot to identify that being a medical doctor, having that public health background, I still have gaps, and those gaps need to be filled by myself at a certain point, but also by others. You also have to learn from others during that simulations, and that's what is happening. I'm still learning from others. I'm still learning from partners I'm working with, and that was the best part of that simulations. Thank you.
Thank you very much, Jerry. Thank you to all the panelists for your insights. We've got a few minutes to take some questions, and I've got a few lined up for you from the question and answer box as people have been typing in. But I just wanted to, say thank you from all of us. And really, for me, the key things that are coming through is the importance of being able to work with these transversal, these interprofessional skills. That technical skills alone are not going to be enough. The importance of preparation through training and exercises and practice that all of you have spoken about, and keeping affected people and patients at the center of this. And I think actually, Jerry, your sort of final point about how we can always continue to learn, so the learning doesn't stop, and all of you spoke about this, particularly Julie, that we need to keep learning and keep revising these frameworks as we go, because particularly in emergencies, they're going to change, they could change very quickly, and making sure then that you have people to fill those gaps, as Jerry says, and to make sure that we deliver the best service that we can in health. So thank you for those insights. Thank you for sharing your time. I've seen a few questions pop up. So I know, Professor Michael, you wanted to answer one, which was about, did we have this type of program before the pandemic, or did we develop it once the pandemic started, or did you develop it?
We did have it before the pandemic, and I think that really involved a lot of foresight. We started back, I think, in 2013 on this whole activity. There's been a lot of research, and development in the United States as well in these areas. But that doesn't mean that we can stop. I think that we can have to learn from the pandemic and modify what we do as well.
Okay, thank you very much. Thank you for that. And then there's a couple I've seen pop up that one in particular I thought was useful, and I don't know who's going to answer it, but the question was about the role of youth. And I suppose what I'm thinking is that these competency frameworks are designed by people who have been in their careers for a long time. But how can people who are starting out their careers and coming through, how do they contribute to these kind of competency frameworks and the type of training that professionals receive? I don't know who wants to take that. Maybe either Julie or Libby or Neil.
I'll chime in first, Andrew. Libby's politely put her hand up. I was just thinking they look like they were using some thinking time. I think it starts from my perspective as the onus of people who are creating competencies to realise that students and educators themselves have a really constructive voice to add, and to seek out that voice, seek out that input, because these things are only useful if they give you the benefits that you're looking for. And hence, is it meaningful to the person that's going to be the receiving end of that? That's one of the first things you want to be checking out.
Okay, thank you. And Libby, you wanted to add to that, did you?
No, Neil said it. It's about working. What we do whenever we write our competency framework is we take it back to the stakeholders and we get them to check it and recheck it, and we make it open access and say, give us the comments, help us adapt it. We know we get the subspecialty specialists, the professional specialists, and everybody involved. But just to say, actually, we used the students a lot in the UK in the end, which was great. And there's obviously a lot of issues with regulation and things like that. But the competency frameworks, they went in as the non-registered support staff role. And they loved it because they got hands-on with patients, you know, much more than they're normally allowed to on their placements. And it's made us rethink. Some people are rethinking about the student training. And actually, do we give them all? In the UK, we have something called the care certificate, which is what anybody needs in order to do patient care. And actually do put all medical students through that so that they have those basic skills. So when a surge comes, they're ready and able to come and do some of these skills on the ward, much more beyond what their professional training has given them the opportunity so far.
Thank you. Thank you for that. So it's about almost a sort of co-creation, I guess, of people all sort of giving in their inputs and things like that. So Andrea, I just need to ask, do we have the final questions for the feedback? Or
Yes, we have.
Okay. So we've got about 4 minutes left. So perhaps if Andrea, if you could put these questions up. We'd ask you to rate this webinar. The feedback that you provide is always really very useful, and you'll see that I can't vote and neither can the rest of the panelists. So we hope we get the truth from this. And so what we'd like you to vote on is how you rated this webinar, whether you found it inspiring, that you have lots to think about, whether it was excellent, informative and useful, good, you found some of it interesting, or poor, it was a waste of your time. And perhaps while you do that, I've just got one quick final question that I need a 30-second answer on, but somebody was asking about autonomy. So giving people autonomy to work in these emergency situations. I wonder if Libby or Julie, you could talk a bit about that.
Yeah, I think to give someone autonomy, you have to create a culture of trust. So that people believe that they have the opportunity to actually autonomously practice. So I think it's around the team, as we've talked about, and it's around ensuring that people feel safe to practice to the top of their license, or to practice in a way that they possibly haven't previously without direct supervision. So it's about the safety that we create and the trusted environment that we create.
Brilliant, thank you. So it's about basically empowering people to use the skills that they have and the knowledge that they have. Thank you very much. So I think that brings us to the end. We've got 2 minutes left, and during that time, I would like to thank the panelists again, but also thank all of you for tuning in from around the world. It's been really sort of inspiring to see how many people have attended, and I hope you've all found it useful. The links should have been put up. I know I saw that Libby had put some links up. I know Andrea has, and I know she has the links for the framework that Professor Michael developed, and hopefully for the WHE strategy as well, which has our own competency framework in it that we're currently revising. They will be on, so the links will be on the Open WHO National Language Channel. The recording of this webinar will be posted on the YouTube channel. And just to let you know that our next webinar in this series is on the 6th of July, which is World Zoonosis Day. The program for that will be out in the coming weeks, and you'll receive an invitation to that. So for now, it just remains for me to say thank you. And with that, I'll close this meeting. Thank you very much.